Hi everyone, welcome to the RSNA Radiographics podcast. My name is Lily Wang, a neuroradiologist from the University of Cincinnati. Today we have a special guest, Dr. Jenny Joyce, my neuroradiology colleague from the University of Cincinnati, with a special interest in head and neck imaging. Today's topic is very practical. The article is by Dr. Sato Matsuoka et al. From the National Cancer Center in Kashiwa, Japan. We've all seen patients CT or MR of the neck with lymphadenopathy before a known primary is diagnosed. This article gives us an approach on how to find the primary or detect its absence.
Yeah, diagnosis can be especially challenging on physical exam alone, especially if the patient presents with a neck mass. If we can find the primary site on imaging, this can swift-in the diagnosis and the optimal treatment can be started.
How do we work up these patients with imaging?
So CT or MRI with contrast medium is usually the first-line imaging exam for patients with cervical lymph node metastases from an unknown primary site. CT can be used to help identify the primary, including in the thorax or the abdomen, assess the nature of the neck mass, and determine the distribution and location of the cervical disease. MRI provides excellent tissue contrast and is superior in depicting normal structures such as the mucosa, the submucosal fat tissue, muscles, particularly for evaluation of the nasopharynx and oropharynx. MRI is also less susceptible to dental artifacts compared to CT. Ultrasound is useful in patients with suspected primary tumors in the thyroid or major salivary glands. In addition, FDG PET/CT can be performed. In a meta-analysis by Rustovan et al., it showed an additional 25% detection rate with PET-CT compared with CT and MRI.
What are some common places that we can look for a primary tumor?
So the most common primary sites for squamous cell carcinoma, cervical lymph node metastases from an unknown primary tumor are the oropharynx, including the palatine tonsil, which accounts for 45%, and the base of the tongue, which is about 44%. Also the hypopharynx and the nasopharynx.
So what are we looking for in the oropharynx? Why is that HPV-positive tumors can be so challenging to diagnose on both physical exam and imaging?
This is a really important area. In patients with cervical lymph node metastases from an unknown primary tumor, oropharyngeal cancer is the most common, accounting for 90% of the cases. HPV-positive tumors tend to grow in the deep tonsillar crypts of the palatine and lingual tonsils after chronic infection, so they can be really occult on physical exam. On imaging, the tumor can be the same attenuation on CT and signal intensity on MRI as the respective normal tonsillar tissue. Therefore, if the interpreting radiologist knows where to look in the neck for the primary based on the level of lymph node metastasis, then this can aid in diagnosing the primary lesion.
So how do we evaluate the tonsils? They always seem heterogeneously enhancing and a little bit irregular.
So simple comparison between the left and the right sides of the palatine tonsils can be especially useful when identifying tumors. However, it can be difficult to diagnose the presence of a tumor with certainty due to the physiologic difference between the two sides of the palatine tonsil. Disruption of the pharyngeal constrictor muscle, which has low signal intensity on T2 weighted imaging, is suggestive of small tumors extending into the parapharyngeal space.
Besides the oropharynx, are there any other additional sites in the head and neck that are challenging to diagnose on both physical exam and imaging?
Yes, hypopharyngeal cancers involving the posterior oropharynx and the postcricoid region can be especially challenging to see on endoscopy, making the initial diagnosis quite difficult. If any suspicion is identified in these areas on imaging, it can help guide potential biopsy and hopefully a successful diagnosis.
Okay, what about the nasopharynx?
So the nasopharynx should also be assessed during any evaluation of a tumor of unknown primary, as cervical lymph node metastases from the nasopharynx can also be seen at levels 2 and 3. This is one of the rare instances where MRI is actually the best imaging modality used for diagnosis, based on the mucosal layers of the nasopharynx and how squamous cell carcinoma grows here, with disruption of the normal striated pattern in the nasopharynx.
Okay, is there something we should look for in the thyroid?
So lymph node metastases from the thyroid gland tend to be cystic or with calcification. Lymph nodes seen at levels 4, 5, and 6 should prompt a more thorough evaluation of the thyroid gland. These are more typically diagnosed with ultrasound.
How about the salivary glands?
So these cancers can also be challenging on physical exam since the glands can be mistaken for lymph nodes. On imaging, the anterior facial veins are useful for distinguishing a submandibular tumor origin versus a subjacent lymph node. A lymph node would be separated from the gland by the vein in this instance.
Those are indeed very important areas to check. When a patient presents with a neck mass of a non-primary, which lymph node levels are the most common and where do we trace back to the primary?
So, squamous cell carcinoma of unknown primary with lymph node metastasis often occurs at nodal levels 2 and 3. And in recent reports, these were mostly related to human papillomavirus HPV positive squamous cell carcinoma of the oropharynx. HPV is an important biomarker of oropharyngeal squamous cell carcinoma, which is also positive around 60 to 90% in cancers with an unknown primary. So, in cases of lymph node metastasis at nodal levels 4 and 5B, a primary lesion located outside of the head and neck region should also be considered. One clue for detecting the primary lesion in imaging is the disruption of anatomic structures, which can help in identifying small mucosal lesions or submucosal tumors at each subsite.
Okay, so when we're looking at imaging, what are some features that can suggest metastases from HPV-associated oropharyngeal cancer?
So, one characteristic imaging finding that suggests metastasis from an HPV-associated oropharyngeal cancer is cystic change in the lymph node metastases. Up to 35% of HPV-positive P16 oropharyngeal cancers present with cystic lymph nodes.
What's the difference between a cystic node and a necrotic nodule? Aren't they kind of hypodense, both of them?
So, cystic change is identified when the lymph node has a more homogeneous fluid content with a thin wall, versus a necrotic lymph node usually has a thicker wall with more heterogeneous hypodensity.
Okay, that's helpful to know. Yeah, you mentioned that the squamous cell carcinomas can be cystic. What other primary tumors can give rise to cystic nodes?
So, 20 to 50% of thyroid papillary carcinoma metastases are cystic, but only 6 to 9% are purely cystic. The cystic changes could be caused by colloid accumulation or hemorrhage. About 2% of melanomas are cystic. One also important thing to note is that people think about brachial cleft cysts when they see cystic lesions in the neck, especially if they're solitary. Second brachial cleft cysts can be located along the anterior border of the sternocleidomastoid muscle, just lateral to the carotid space and posterior to the submandibular gland. It is important to consider cystic metastases in someone other than a child with no prior history of a neck mass.
That's a great reminder because sometimes you see a cystic lesion and you think, brachial cleft cyst in the neck. I've seen those cases before. How about if we see homogeneously enhancing lymph nodes or homogeneous lymph nodes?
So homogeneous lymph nodes tend to be histologically non-keratinizing or without necrosis. And this can be seen with lymph nodes from a nasopharyngeal primary. P16 positive oropharyngeal squamous cell carcinoma also tend to be non-keratinizing, however, they have a higher frequency of cystic change. ADC values therefore tend to be lower in non-keratinizing squamous cell carcinoma in the nasopharynx and P16 positive squamous cell carcinoma. Lymphoma can also be added as a differential diagnosis in certain situations because they also tend to be homogeneous on imaging.
I see. So when I see calcs and calcifications in the nodes, I think of papillary thyroid cancer. Are there any others that tend to calcify?
Oh yes, that's often true, but don't forget that certain forms of squamous cell can also calcify in addition to adenocarcinoma. However, it is less frequent.
Okay. And how about those hypervascular nodes? I think of like thyroid, but is there anything else?
So, thyroid cancers like papillary and medullary carcinoma can indeed be hypervascular. However, you should also think about olfactory neuroblastoma and renal cell carcinoma.
Okay. So if we don't find a primary in the head and neck, do we need to look elsewhere, and where do we look?
So primaries outside the head and neck are rare, only about 1%. If you see supraclavicular lymph node metastases, you should think about lung, breast, uterine, cervical, stomach, ovarian, and pancreatic cancer. These are generally adenocarcinomas. For squamous cell carcinoma, they are most commonly from uterine cervical, followed by the lung, vulva, and esophagus.
Wow, there's so much to consider when we're searching for tumors of unknown primary origin with cervical lymphadenopathy. However, I think this information is really helpful to the interpreting radiologist for initial staging. I feel more confident and have an approach next time when I come across a patient with a CT with metastatic lymph nodes. Thank you so much, Dr. Jenny Joyce, our head and neck neuroradiology podcast guest for this episode of Radiographics. I hope you all enjoyed it, and please take a look at this great article with the images online. Thank you.
Thank you.